Have you ever paused to consider the sheer precision that allows you to simply lift your arm, blink your eyes, or, even just breathe without consciously thinking about it?
Hmm.
It's an incredibly intricate yet seamless dance of nerves and muscles orchestrated perfectly in your body. But what if that delicate dance suddenly faltered?
Right.
Or what if a tiny molecule, perhaps from an ancient plant, could bring that entire system to a grinding halt? Today, we're taking a deep dive into exactly that remarkable territory.
It's truly a marvel of biological engineering. We're going to explore the intricate world of the nervous system's command center, specifically focusing on how it controls our muscles and internal organs.
Okay.
Our journey will center on the fascinating acetylcholine receptors and the powerful substances, both natural and synthetic, that interact with them.
Acetylcholine receptors, right.
From ancient arrow poisons used for hunting to cutting-edge modern surgical anesthetics and even the innovative aids we use to help people quit smoking, you'll discover how it's all connected by a common fundamental thread: the precise language of chemical communication within the body.
Wow.
By the end of this deep dive, you'll understand this information with the clarity and depth of a professional in the field.
Our guide for this exploration is an authoritative text from the world of pharmacology, packed with profound insights into how these critical systems work. Our mission for you is to distill the most essential, truly mind-bending, and clinically relevant information.
Absolutely.
We want you to master this complex subject, understanding it not just on the surface, but with the comprehensive grasp that medical professionals rely on every single day. So let's unpack this incredible system, beginning with its very core, a tiny but mighty protein that quite literally revolutionized our understanding of how drugs work on a molecular level.
It's the nicotinic acetylcholine receptor, or nAChR for short. And it's a critical mediator of neurotransmission throughout your entire body. When we talk about receptors, this one is practically a celebrity.
A celebrity receptor. So if it's so crucial, where in the body do we find these pivotal receptors, and what precisely do they do? What's their main job?
Well, their primary role is mediating neurotransmission at key junctions. You'll find them postsynaptically at the neuromuscular junction. That's the critical link where your nerve communicates with your muscle, enabling all voluntary movement.
Okay, nerve to muscle. Got it.
Imagine every step you take, every blink, every gesture. It all starts with a signal crossing this junction. They're also found in peripheral autonomic ganglia, which control the involuntary functions we rarely think about, like your heart rate, digestion, blood pressure.
The automatic stuff.
Exactly. But what's really fascinating is their significant role in the central nervous system, where they modulate the release of other neurotransmitters from presynaptic sites. Think of them as tiny traffic controllers, fine-tuning the flow of information in your brain.
And it's named nicotinic. Interesting. Because both our body's natural neurotransmitter, acetylcholine, and the alkaloid nicotine, found in tobacco, can stimulate it. What an interesting way to name a receptor, tying a natural compound to such a fundamental bodily process.
It really highlights a powerful historical and functional connection. And importantly, it's not a single monolithic receptor. We identify distinct subtypes based on their unique subunit composition.
Aha, subtypes.
These subtypes are strategically located for specific functions. We have the NM subtype, that's the muscle type, found exclusively at the neuromuscular junction, mediating muscle contraction.
Hem for muscle. Makes sense.
Then there's the N, or neuronal type, which you find in autonomic ganglia and the CNS, involved in a much broader, more diverse range of neural signaling. This structural specificity, even within the same family, is absolutely critical.
Why is that so critical?
Well, it's what allows scientists to design drugs that target specific functions without causing widespread unwanted effects. Precision targeting.
That makes incredible sense. So when acetylcholine or even nicotine binds to one of these receptors, what's the actual molecular event? How does it translate that chemical signal into an electrical one, ultimately leading to something like a muscle contracting? How does that key turn the ignition?
Right. So when acetylcholine, or an agonist like nicotine, binds to the nicotinic AC receptor, it causes a rapid, direct influx of positively charged ions. We call these cations.
Cations, positive ions.
Mainly sodium and potassium, and sometimes calcium, rushing into the postsynaptic cell. This sudden rush of charge is precisely what initiates the electrical signal. It's an almost instantaneous transformation.
And in muscle cells, that immediate electrical signal is called an EPP, or end plate potential. That's the direct trigger for muscle contraction.
Correct.
And in peripheral ganglia, it's known as an EPSP, or excitatory postsynaptic potential, vital for transmitting nerve impulses. It sounds like a beautifully fast and efficient system.
It absolutely is. And what's truly mind-bending is the historical significance of this receptor. The nicotinic ADA receptor wasn't just a receptor. It was the first pharmacological receptor concept ever defined over a century ago.
The first one. Wow.
This makes it the prototypical receptor, a true landmark in molecular pharmacology. Its discovery literally laid the groundwork for how we understand any drug interacts with the body at a molecular level.
And it was those classical studies involving curare, that terrifying, paralyzing arrow poison,
Yes.
came alongside nicotine, that stimulating alkaloid, that were instrumental in its initial discovery and characterization. Imagine, the very poison used by ancient tribes to hunt game centuries ago now guides our most advanced surgeries. That's a direct link from survival to sophisticated medicine.
It's a compelling evolutionary story, isn't it? Nature, in its cleverness, evolved a vast number of toxins, peptides, terpenoids, alkaloids, specifically to block these receptors, either for predation or protection.
Nature's own chemical warfare.
You could say that. This strategy is seen across diverse species, from marine vertebrates to mammals. For example, alpha toxins, potent inhibitors of neuromuscular transmission derived from the venoms of kraits and cobras.
Snake venoms.
Exactly. They became invaluable scientific tools. They're excellent probes because they can be easily radio-labeled, allowing researchers to essentially tag and track the receptor, which was crucial for its study and eventual isolation.
So the toxins help them find the receptor.
Pretty much. These toxins are literally tools that nature provided, which scientists then leveraged to unravel fundamental biological processes, illustrating a profound serendipity in scientific discovery.
That's incredible. But how did scientists actually get enough of this tiny protein to study it in such detail? You can't just scoop it up from muscle tissue, right? It must be present in tiny amounts.
That's a great question, and it's where nature gave us a fascinating shortcut. Certain aquatic species, like the electric eel, Electrophorus, and the electric ray, torpedo.
Electric eels. Really?
Yes, they evolved specialized electric organs. These organs are remarkably rich sources of nicotinic receptors, with up to 40% of their membrane surface being excitable and packed with these cholinergic receptors.
40%, that's huge.
It is. Contrast that with vertebrate skeletal muscle, where motor end plates occupy less than 0.1% of the cell surface. These electric organs were absolutely crucial for initial isolation efforts because they offered such an incredibly high density of the target protein. It was like finding a gold mine instead of panning for flakes.
So once they had these incredibly rich sources, what were the next steps in unraveling the receptor structure? How did they go from, eel organs to understanding the molecule?
Using those alpha toxin probes we talked about, researchers achieved a monumental scientific breakthrough. They were able to purify the receptor from torpedo, then isolate the cDNAs, the genetic blueprints, of its individual subunits.
The DNA blueprint.
This allowed them to clone the genes for multiple receptor subunits from mammalian neurons in muscle.
And once they had the genetic blueprints, they could really start to connect the dots between the receptor structure and its precise function, right?
Exactly. They developed cutting-edge techniques, simultaneously expressing various permutations of these subunit genes in cellular systems.
Like mixing and matching the parts.
Sort of, yes. And then meticulously measuring the binding of molecules and the resulting electrophysiological events. This allowed scientists to correlate the precise functional properties of different receptor subtypes with their detailed primary structures. It was a monumental leap in understanding drug action.
Connecting structure to function.
What's truly fascinating is that the nicotinic receptor shares significant structural homology, meaning a shared evolutionary blueprint, with other pentameric ligand-gated ion channels, such as the 5-HT3 receptors and receptors for inhibitory amino acids like GABA and glycine.
So it's part of a bigger family of receptors.
Precisely. This hints at a broader family of crucial receptors, all built on a similar fundamental architectural plan.
So it's a pentamer, meaning it's made up of 5 individual subunits, each weighing roughly 40 to 60 kilodaltons.
That's correct. These 5 subunits are arranged in a precise fashion around a central pseudo-axis of symmetry, essentially forming a central channel.
Okay, like segments of an orange around the middle.
That's a decent analogy. Each subunit has a distinct architecture. An amino terminal region, about 210 amino acids long, forms a large extracellular domain, the part that sticks out of the cell.
The bit that sees the outside signal.
Right. Then there are four membrane-spanning domains, imaginatively called TM1 through TM4, which anchor the subunit within the cell membrane. The region between TM3 and TM4 forms most of the cytoplasmic component, meaning it's on the inside of the cell.
Okay.
And here's the crucial part. The TM2 region of each of the 5 subunits collectively lines the internal pore of the receptor. This specific arrangement of the TM2 helices is what forms the actual ion channel itself.
Ah, so TM2 from each subunit comes together to make the tunnel.
You got it.
Let's dig a bit deeper into the specifics of the muscle nicotinic receptor, the NM. How are its subunits configured for muscle action?
Right, the M. For vertebrate skeletal muscle NM receptors, they are indeed pentamers, but composed of 4 distinct subunits. 2 alpha subunits, 1 beta, 1 gamma, and 1 delta. This is a very precise stoichiometric ratio of 2.1.1.1.
2 alphas, 1 beta, 1 gamma, 1 delta.
Got it.
It's an interesting detail that in mature, innervated muscle end plates, where the nerve fully connects to the muscle, the gamma subunit is actually replaced by an epsilon subunit.
So it changes as the muscle matures.
Yes, this subtle change reflects the receptor's maturation. Despite their distinct roles and locations, these individual subunits share about 40% identity in their amino acid sequences, indicating conserved regions vital for the receptor's fundamental function, alongside subtle differences that give them their unique properties. So it's an asymmetrical molecule, quite large at 290 kilodaltons, with the bulk of its non-membrane spanning domain on the extracellular surface. And it's present at incredibly high densities, 10,000 receptors per square micrometer, in critical areas like the motor end plate or the electric organs of torpedo. That density alone screams importance at these communication hubs.
It absolutely does. This high density ensures rapid and efficient signal transmission. And it's critical to understand that the agonist binding sites, where molecules like acetylcholine bind, occur at the interfaces between these subunits.
Not just on one subunit, but between them.
Correct. In muscle, only 2 of the 5 interfaces, specifically the alpha-gamma and alpha-delta interfaces, actually bind agonists. Both subunits contributing to that interface play a role in ligand specificity, meaning they collectively determine how a molecule like AT is recognized and bound, ensuring a precise fit.
Fascinating. And what about the neuronal nicotinic receptor, the NN? Is its subunit composition as neatly defined as the muscle type?
The N receptors, found in ganglia and the CNS, are also pentamers. However, they exhibit a much wider diversity of subunits than the muscle type, ranging from alpha-2 through alpha-10 and beta-2 through beta-4.
Wow, that's a lot more variety.
It is. What's truly fascinating here is that while not all possible combinations lead to functional receptors, the sheer diversity is vast. It actually exceeds the current capacity of ligands, meaning the drugs or natural compounds we use, to distinguish subtypes solely based on their selectivity.
So we have more receptor types than drugs to specifically target them.
In many cases, yes. It makes studying them a highly complex and ongoing area of neuroscience and pharmacology. This diversity is what allows for incredibly nuanced and varied signaling in different parts of the brain and throughout the autonomic nervous system.
So once an agonist binds and those 5 TM2 alpha helices open up that central channel, how incredibly fast are we talking about ion flow? Is it like a floodgate opening?
The speed is truly impressive and essential for rapid bodily responses. Agonist-mediated changes in ion permeability occur through that intrinsic cation channel, which is an integral part of the receptor structure. Measurements reveal ion translocation rates of an astonishing 5 by 107 ions per second.
50 million ions per second. That's staggering.
It is. The channel is generally non-selective among cations, highly permeable to sodium, potassium, and in some cases calcium. However, the vast majority of the electrical current is carried by sodium ions, leading to that crucial depolarizing effect.
And the coupling of binding and channel opening is incredibly tight, right? In the muscle M receptor, the simultaneous binding of 2 agonist molecules results in a rapid conformational change, a swift shift in the receptor shape that instantly opens the channel, immediately triggering that cellular response.
Exactly.
It's an exquisitely tuned mechanism designed for rapid and reliable signal transmission.
That's the elegant design at play. It's a perfect example of how molecular structure directly dictates function, enabling vital processes like muscle contraction to happen in a fraction of a second.
That's a phenomenal deep dive into the receptor itself. Now, let's explore how this fundamental molecular understanding has been applied, particularly in medicine. We absolutely have to talk about the legacy of curare, how it transformed from an ancient arrow poison into a pivotal, life-saving tool in modern anesthesia.
Right. Curare. What's truly remarkable here is that its journey into clinical medicine began with the meticulous scientific work of Claude Bernard in the mid-19th century.
Mid-1800s.
Yes. He made the profound discovery that curare's action was specifically localized at or very near the neuromuscular junction, not directly on the muscle or the nerve itself. This was a critical conceptual leap.
So it wasn't just generally paralyzing everything.
No, it was specific, proving that drugs could target a specific point of communication between tissues, rather than having a general diffuse effect. This insight was foundational for the entire field of pharmacology.
Curare, as a generic term, refers to various South American arrow poisons used by indigenous communities for hunting. Death for the hunted animal resulted from skeletal muscle paralysis, including the vital respiratory muscles.
Right. Paralysis, including breathing.
I can only imagine the mystique surrounding its preparation, often entrusted to tribal shamans. It's like a secret, ancient technology.
It was indeed shrouded in mystery and tradition. But European explorers and botanists, driven by scientific curiosity, became fascinated, bringing samples back to Europe for study.
Science meets traditional knowledge.
It was a powerful fusion. The curares from eastern Amazonia, for example, came from strychnos species, which contain powerful quaternary neuromuscular blocking alkaloids. Other species contain different types, like tertiary strychnine-like alkaloids.
But the real game changer for medicine was in 1932, when West daringly used highly purified fractions of curare in patients suffering from tetanus and spastic disorders, seeking muscle relaxation.
A bold move back then.
And then King established the essential chemical structure of tubocurarine, the active component, in 1935. This moved it from a mysterious poison to a precisely understood therapeutic agent.
And then came the truly groundbreaking report by Griffith and Johnson in 1942, which marked the first clinical use of curare for muscle relaxation during general anesthesia. This forever revolutionized surgical practice.
How so? What was the big change?
Before this, surgeons had to rely on incredibly deep, often dangerously high levels of general anesthesia to achieve sufficient muscle relaxation. Curare allowed for much lighter, safer anesthesia.
Less risk from the anesthetic itself.
Exactly, leading to more precise, less traumatic surgeries and significantly improved patient outcomes. It transformed surgery from, well, almost a brute force endeavor into a more controlled, refined procedure.
So now we have modern neuromuscular blocking agents, or NMBAs, that fall into two main classes.
That's right. We have depolarizing agents, of which acetylcholine is virtually the only one in general clinical use today.
It's just acetylcholine, okay.
And then there are multiple competitive or non-depolarizing agents that are widely available and used. This distinction in their mechanism is key to understanding their clinical behavior.
And their primary clinical uses are quite specific and impactful, aren't they?
Yes, primarily facilitating endotracheal intubation, making it much easier and safer to insert a breathing tube into a patient's airway during anesthesia or in emergencies.
Putting in the breathing tube, crucial.
Very. Secondly, they are crucial for relaxing skeletal muscle during surgery. This relaxation allows the surgical team to operate with greater precision, reduces patient movement, and minimizes the risk of trauma during delicate procedures.
When we look at the chemistry and structure-activity relationships of these agents, what are the key features that determine their function? How does the shape matter?
Oh, it matters immensely. Early structure-activity studies were vital, leading to compounds like the polymethylene-based trimethylammonium series, commonly known as methonium compounds.
Methonium compounds.
Decamethonium, with 10 carbon atoms between its two quaternary nitrogens, was found to be the most potent at the neuromuscular junction. But a crucial insight came with hexamethonium, which has only 6 carbon atoms.
So just a shorter chain.
Right. Remarkably, it was essentially devoid of neuromuscular blocking activity, but proved to be an incredibly effective ganglionic blocking agent.
Whoa, different target entirely.
Exactly. This small structural change from 10 carbons to 6 fundamentally shifted its target selectivity, highlighting the exquisite specificity of these receptors and how subtle chemical differences can have profound pharmacological effects.
So the competitive agents like tubocurarine and newer ones like atracurium or rocuronium are generally bulky, rigid molecules. But depolarizing agents like decamethonium and succinylcholine tend to have more flexible structures, allowing for free bond rotations. That structural difference is absolutely key to their differing mechanisms of action, isn't it?
It absolutely is. Let's break down those mechanisms. Competitive antagonists work exactly as their name implies. They bind to the nunum receptor, but crucially, they do not activate it.
They just sit there.
They just sit there. Instead, they competitively block the binding of acetylcholine, essentially putting a physical roadblock in the way of the natural neurotransmitter. This prevents acetylcholine from reaching its binding site, thereby preventing muscle contraction and causing a placid paralysis.
But succinylcholine, the depolarizing agent, works in a fundamentally different way. It does depolarize the muscle membrane just like acetylcholine, but it sticks around much longer.
Precisely. Succinylcholine activates the receptor, causing initial depolarization, but it persists much longer at the neuromuscular junction because it's highly resistant to acetylcholinesterase, ACE, the enzyme that rapidly breaks down and inactivates acetylcholine.
So the cleanup crew can't get rid of it quickly.
Right. This prolonged depolarization leads to what we call a phase I block. You might observe a brief period of transient, repetitive muscle excitation, sometimes seen as visible twitching or fasciculations, immediately followed by a complete block of neuromuscular transmission and the desired flaccid paralysis.
So if it's depolarizing the membrane, activating it, why does that prolonged depolarization ultimately lead to a block? That seems counterintuitive.
That's a great question, and it gets to the core mechanism. After the initial opening and activation by succinylcholine, the perijunctional sodium channels, these are the voltage-gated channels right next to the end plate, essential for propagating the muscle action potential, they close.
Okay, they shut down.
And crucially, they will not reopen or repolarize until the end plate itself repolarizes. Since succinylcholine keeps the end plate persistently depolarized, these perijunctional sodium channels remain in a functionally inactive closed state.
Ah, they get stuck closed because the area stays depolarized.
Exactly. This effectively shields the rest of the muscle fiber from any further electrical activity, blocking the signal downstream and ensuring complete paralysis. It's a block caused by sustained activation, essentially.
And to complicate things further, with increasing concentrations of succinylcholine or prolonged administration, the phase I block can actually convert into a non-depolarizing phase II block. This sounds like a significant clinical challenge.
It is a critical clinical distinction that requires careful monitoring. The response to peripheral nerve stimulation during a phase II block actually resembles that of competitive agents.
So it starts looking like the other type of block.
It does, making it tricky to diagnose without careful assessment. What's more, reversal of a phase II block by anti-AT agents, drugs like neostigmine, is notoriously difficult to predict and must be undertaken with extreme caution, unlike the more straightforward reversal seen with competitive agents.
Not easy to reverse them.
Not always predictable. Our source text highlights key contrasts, such as the end plate membrane potential, depolarized in phase I, repolarized in phase II, onset speed, immediate versus slow, dose dependence, and the distinct responses to repetitive nerve stimulation, which are unique for each phase. Understanding this is absolutely essential for professional level practice.
Other blocking mechanisms exist, for instance, botulinum toxins, which interfere with acetylcholine release.
Right, Botox.
But these are generally not used for broad neuromuscular blockade in surgery, except for their specific local therapeutic uses, which we'll dive into later.
Yes, the progression of paralysis itself is also quite specific and predictable, which is vital for patient management. With competitive agents, following an intravenous injection, motor weakness gradually progresses to total flaccid paralysis.
It's a gradual onset.
Relatively, yes. Interestingly, the small, rapidly moving muscles, such as those of the eyes, jaw, and larynx, relax before the larger muscles of the limbs and trunk.
Eyes and jaw first. Interesting order.
It is. Ultimately, the intercostal muscles and the diaphragm essential for breathing are paralyzed, leading to cessation of respiration.
And thankfully, recovery usually occurs in the reverse order, meaning the diaphragm is typically the first muscle to regain function, which is absolutely critical for the patient's ability to breathe independently again.
Absolutely critical. For acetylcholine, after a single intravenous dose, you immediately see those characteristic brief muscle fasciculations, especially over the chest and abdomen, within seconds.
Very fast onset.
Incredibly fast. Relaxation is rapid, often within 1 minute, reaching its maximal effect within 2 minutes, and generally disappears within 5 minutes. A transient period of apnea, or cessation of breathing, often occurs at the time of maximal effect.
The rapid disappearance of succinylcholine's effects is due to its efficient hydrolysis, or breakdown, by plasma and hepatic butyrylcholinesterase, an enzyme found in the blood and liver. But what about the potential for muscle soreness and the critical risk of electrolyte imbalance?
You've hit on vital clinical considerations. Muscle soreness is a known, though generally transient, side effect that can follow administration. And crucially, during that prolonged depolarization phase, muscle cells can lose significant potassium ions and gain sodium, chloride, and calcium.
Potassium loss. That sounds risky.
It can be very risky. In patients with extensive soft tissue injury, such as burns, trauma, or certain neurological conditions, the rapid efflux of potassium following acetylcholine administration can be life-threatening, causing severe hyperkalemia.
High potassium levels.
Dangerous.
Extremely dangerous. This makes acetylcholine contraindicated or requires extreme caution in such specific patient populations. Understanding these risks is paramount for patient safety.
Do these neuromuscular blocking agents affect the brain or other parts of the nervous system beyond the muscles? Can they cross the blood-brain barrier?
Generally, no. For quaternary neuromuscular blocking agents like tuberculine, they generally have virtually no central nervous system effects at clinical doses because their chemical structure prevents them from effectively penetrating the blood-brain barrier.
So the brain is usually safe.
Typically, yes, your brain remains unaffected, even if your muscles are completely paralyzed. This is a critical safety feature for their use in surgery.
But they can affect autonomic ganglia, which control involuntary functions like heart rate and blood pressure. How does that manifest? Yes, they show variable potencies in producing ganglionic blockade. What's important to remember is that ganglionic blockade caused by tuberculine and other competitive agents is actually reversed or antagonized by anticholinesterase agents, similar to their action at a neuromuscular junction.
So the reversal agents work there too.
They do. This provides a therapeutic target if unwanted ganglionic effects occur.
So tuberculine, for example, can cause partial blockade at autonomic ganglia and the adrenal medulla, which can lead to a fall in blood pressure and an increase in heart rate. But newer agents like atracurium and rocuronium are much more selective, showing less ganglionic blockade. That's a desirable trait, right?
Exactly. You want to preserve the body's natural ability to regulate its own blood pressure and heart rate during a surgical procedure to maintain stability. However, it's worth noting that pancuronium, while effective, has a distinct vagolytic action, meaning it blocks muscarinic receptors.
Blocking the vagus nerve's influence. Essentially, yes, which can lead to a significant increase in heart rate, a key side effect to monitor. Succinylcholine, while rarely causing significant ganglionic blockade at typical relaxation doses, can also cause complex cardiovascular effects due to successive stimulation of vagal ganglia, leading to transient bradycardia, and sympathetic ganglia, leading to hypertension and tachycardia.
So succinylcholine can go both ways with heart rate.
It can be complex. It's a nuanced interplay of effects depending on the agent and the specific physiological context.
Let's discuss ADME: absorption, distribution, metabolism, and excretion. These quaternary ammonium and MBAs are generally poorly absorbed from the GI tract, which is why intravenous administration is the standard for rapid onset.
Correct. While intramuscular absorption is adequate, the intravenous route is preferred for its rapid and predictable onset. When long-acting competitive agents like ditubocurin and pancuronium are administered, the initial blockade may diminish after about 30 minutes.
It wears off a bit. Well, it's often due to redistribution of the drug from the bloodstream into various peripheral tissues. However, residual blockade and plasma levels persist, meaning that if subsequent doses are given, they can lead to drug accumulation as the tissues become saturated.
So it builds up over time.
It can. This is why intermediate duration agents are often preferred when repeated dosing is anticipated.
And the metabolism differs significantly between agents, which is crucial for patient selection. Aminosteroids like vecuronium and rocuronium contain ester groups that are primarily hydrolyzed or broken down in the liver. Their metabolites often have about half the activity of the parent drug.
And these intermediate duration agents are cleared more rapidly by the liver than pancuronium. But a truly crucial detail for patient care is the metabolism of atracurium and its congener, cisatracurium.
What's special about them?
These agents are unique because they are converted to less active metabolites, not just by plasma esterases, but also by a remarkable process called spontaneous degradation, known as Hofmann elimination.
Hofmann elimination, spontaneous breakdown.
Yes, it's a non-enzymatic chemical breakdown that occurs at physiological pH and temperature. The significance of this is profound. It means atracurium and cisatracurium do not have increased half-lives in patients with impaired renal or hepatic function.
Ah, so they're safer if the kidneys or liver aren't working well.
Exactly. They become excellent choices in those settings, making their elimination largely independent of organ function.
And acetylcholine's extremely brief duration of action is due to its incredibly rapid hydrolysis by plasma and hepatic butyrylcholinesterase. But some patients have an atypical plasma cholinesterase, leading to significantly prolonged recovery times.
Yes, this is a classic example of pharmacogenomics in action. Certain genetic variations, like the ASPIC polymorphism in the butyrylcholinesterase gene, can lead to a less efficient enzyme.
So their genes affect how they break down the drug.
Precisely. For individuals who are heterozygous for this variant, recovery times can be prolonged by 3 to 8 times. For homozygotes, it can be delayed by up to 60 times, leading to prolonged apnea post-surgery.
60 times longer. That's a huge difference.
It is. Additionally, severe hepatic or renal disease or nutritional disturbances can also delay succinylcholine recovery. This underscores the vital importance of considering individual patient factors in pharmacology.
And then there's gadolinium, a newer agent, which is degraded by two purely chemical mechanisms, not enzymatic, a very rapid cysteine induction and a slower extra hydrolysis. The cysteine induction gives it its ultra-short action.
That chemical degradation mechanism is incredibly innovative. And what's truly fascinating here is that the choice of NMDA in clinical practice is far from arbitrary. Therapeutic selection is a sophisticated process.
It's not just picking one off the shelf.
Not at all. It's based on meticulously matching the drug's pharmacokinetic profile, how it's absorbed, distributed, metabolized, and excreted to the anticipated duration of the medical intervention. Clinicians also strive to minimize cardiovascular compromise and carefully consider the specific modes of elimination in patients with pre-existing renal or hepatic failure.
So generally, newer agents have diminished side effects compared to older ones like tubocurine, especially less ganglionic blockade, less vagal response block, and less histamine release. And they're conveniently categorized by their duration of action: long, intermediate, short, or ultra-short.
Exactly. For instance, pancuronium, a prototypical immunosteroid, induces virtually no histamine release, but, as we mentioned, blocks muscarinic receptors, leading to that characteristic tachycardia. Newer immunosteroids like vecuronium and rocuronium largely eliminate this vagolytic effect, making them more cardiovascularly stable choices.
Better for heart rate stability.
Generally, yes. The benzoylusaquinolines like atracurium, cisatracurium, and mavacurium are generally devoid of both vagolytic and ganglionic blocking actions, although they may cause slight histamine release, particularly with rapid administration or higher doses.
So different chemical families have different side effect profiles.
Correct. Atracurium's unique Hoffman degradation makes it a good choice for patients with renal failure. Mivacurium, on the other hand, is very sensitive to plasma cholinesterases, which explains its remarkably short duration of action. Ganticurium, as we noted, is ultra-short acting, primarily through its rapid chemical induction with cysteine. Understanding these nuanced profiles is essential for precise clinical application.
These agents are primarily used for muscle relaxation in surgery, serving as crucial adjuvants to general anesthesia. This allows for lighter anesthesia overall and minimizes respiratory and cardiovascular depression, ultimately shortening recovery times.
They are absolutely central to modern anesthesia, and short-duration NMDAs are excellent for facilitating crucial procedures like endotracheal intubation, laryngoscopy, bronchoscopy, and esophagoscopy when used with a general anesthetic.
And outside the OR, in the ICU.
Yes. Beyond the operating room, continuous infusions of NMDAs are also administered in intensive care units, ICUs, for improving chest wall compliance, making it easier for the ventilator to inflate the lungs, and eliminating ventilator desynchrony, ensuring patients can be adequately ventilated with minimal resistance and patient-ventilator conflict.
Helping the patient work with the ventilator, not against it.
Precisely.
How do clinicians actually measure how effective the blockade is during surgery, ensuring the patient is sufficiently paralyzed, but also monitoring for recovery?
Good question. Assessment is usually performed by stimulating a peripheral nerve, most commonly the ulnar nerve at the wrist, and monitoring the responses from a specific muscle, typically the adductor pollicis, which controls thumb movement.
Watching the thumb twitch, basically.
Essentially, yes. Responses to repetitive or tetanic stimuli are most useful for evaluating the depth of blockade. What's incredibly important for patient safety is that the onset and recovery of paralysis are often faster in airway musculature, like the jaw, larynx, and diaphragm, than in the thumb.
Faster in the airway. That's useful.
Very useful. This physiological difference allows for safe intubation to occur before complete thumb block is achieved, and, critically, allows for safe extubation after only partial thumb recovery, ensuring the patient can breathe independently when it's safe to do so.
And beyond surgery, they're also used in electroconvulsive therapy, or ECT, to prevent trauma.
That's right. The muscular component of the seizure isn't actually essential for the therapeutic benefit in ECT, so NMDAs, typically succinylcholine, combined with a short-acting barbiturate like methotrexate, are used to prevent dislocations or fractures that could result from uncontrolled muscle contractions during the induced seizure.
Making ECT safer. Now, let's turn to synergisms and antagonisms, how these drugs interact with other agents in complex ways.
This is a critical area. Anticholinesterase agents, such as neostigmine, pyridostigmine, and edrophonium, are crucial. They preserve endogenous acetylcholine at the neuromuscular junction and are used to treat overdosage or, more commonly, to reverse competitive blockade post-surgery.
The reversal agents.
Yes. However, they must typically be given concomitantly with a muscarinic antagonist like atropine or glycocarollate to prevent unwanted side effects, such as a dangerous slowing of the heart rate from muscarinic receptor stimulation elsewhere in the body.
So you give two drugs, one to reverse the block, one to block the side effects of the reversal agent.
You got it. It's a balancing act.
And critically, this is a major distinction. Anticholinesterase agents enhance depolarizing neuromuscular blockade rather than reversing it. That's a vital point to remember.
Absolutely vital. And many inhalational anesthetics also potentiate or strengthen competitive blocking agents by stabilizing the postjunctional membrane.
The anesthetic gases make the blockers stronger.
They do. This means that when these anesthetics are used, clinicians need to reduce the NMDA dose. The rank order of potentiation can be quite specific, with desflurane generally causing more potentiation than sevoflurane, which is more than isoflurane, and so on.
And astonishingly, certain antibiotics can also cause neuromuscular blockade, aminoglycosides, for instance.
Yes, this is a crucial drug interaction to be aware of. Aminoglycosides cause blockade by inhibiting acetylcholine release and non-competitively blocking the receptor. Tetracyclines may also cause blockade, possibly via calcium chelation.
Who knew antibiotics could paralyze muscles?
It's a known, though perhaps less common, interaction. Other antibiotics like polymyxin B, colistin, clindamycin, and lincomycin also possess neuromuscular blocking actions, affecting both pre- and postsynaptic sites. Furthermore, calcium channel blockers enhance blockade by both competitive and depolarizing antagonists, necessitating careful dose adjustments.
So blood pressure meds can affect this too.
They can, and the list of miscellaneous drugs that can interact is long, including agents like trimethophan, lithium, opioids, procaine, lidocaine, and quinidine, among many others. This highlights the immense complexity of drug interactions in clinical settings.
So with all this power and precision, what are the critical adverse effects and risks clinicians need to be acutely aware of when using these agents?
The important untoward responses can include prolonged apnea, where the patient stops breathing for too long, cardiovascular collapse, and effects stemming from histamine release. The true IgE-mediated anaphylaxis is rare.
Histamine release, like an allergic type reaction.
Similar symptoms, but usually a direct effect on mast cells, not a true allergy. Various patient factors can contribute to these risks, such as altered body temperature, electrolyte imbalance, especially potassium, low plasma butyrylcholinesterase activity, or underlying conditions like latent myasthenia gravis or Eden-Lambert syndrome, which is associated with small cell lung carcinoma. Reduced blood flow to muscles or decreased drug elimination due to hepatic or renal dysfunction can also exacerbate adverse effects.
And that life-threatening succinylcholine-induced hyperkalemia we mentioned earlier is a severe complication, especially in patients with pre-existing electrolyte imbalance or extensive soft tissue injury.
Yes, due to the rapid and massive release of potassium from intracellular sites into the bloodstream. But what's truly critical for professionals to master is malignant hyperthermia, MH.
MH. That sounds serious.
It is extremely serious. This is a potentially lethal, genetically determined clinical hypermetabolic state that can be triggered by certain inhalational anesthetics, specifically halogenated hydrocarbons and succinylcholine, or their combination.
But a genetic reaction to anesthetics.
Yes. It's characterized by dramatic clinical features: widespread muscle contraction and rigidity, rapid heat production that can reach up to 1 degree C every 5 minutes, accelerated muscle metabolism leading to severe metabolic acidosis, and profound tachycardia.
Wow, that sounds like a metabolic storm.
It is. The initiating event in MH is an uncontrolled release of calcium from the sarcoplasmic reticulum, the calcium storage organelle, within skeletal muscle cells. And it's an autosomal dominant trait, meaning it can be inherited, but often there are no visible signs or symptoms in a patient until they are exposed to these specific anesthetic agents.
So you might not know you have it until you get anesthesia.
That's often the case. The treatment for MH is an absolute medical emergency. It involves immediate intravenous administration dantrolene, which specifically acts to block that uncontrolled calcium release.
Dantrolene is the antidote.
It's the specific treatment, yes. This is combined with rapid cooling measures, administering 100% oxygen, and aggressively controlling the metabolic acidosis. For respiratory paralysis due to NMBA overdose, the primary treatment involves positive pressure artificial respiration with supplemental oxygen, ensuring a patent airway. For competitive blockade, the effects can be rapidly reversed by administering neostigmine or edrophonium.
And if an overdose occurs?
Well, if it's an overdose, a muscarinic antagonist like atropine or glycopyrrolate may also be added to counteract potential bradycardia from muscarinic receptor stimulation.
And some adverse effects like bronchospasm, flushing, and hypotension are actually due to histamine release, especially from agents like succinylcholine, mivacurium, and atracurium, though generally less so than with tubocuring unless administered rapidly.
That's a key distinction. It's typically a direct action on mast cells, causing them to release histamine, and not an IgE-mediated anaphylactic reaction, which is a different type of allergic response.
Okay, different mechanism.
For interventional strategies against toxic effects, neostigmine effectively antagonizes competitive skeletal muscle blockade. But clinicians must be vigilant as it can aggravate hypotension or induce bronchospasm. Sympathomimetic amines may be needed to support blood pressure if this occurs. Antihistamines can also be beneficial for histamine release responses, especially if given before the NMBA.
And then there's a truly game-changing development for reversal. Sugammadex.
Ah, yes, Sugammadex, a significant advance. This is a modified gamma-cyclodextrin that specifically encapsulates and activates rocuronium and vecuronium, reversing blockade within a remarkable 3 minutes.
3 minutes? That's incredibly fast.
It truly is. Approved in the U.S. in 2015. However, its clearance is markedly reduced in patients with impaired renal function, so it must be avoided in that population. While it has reported side effects like dysgeusia, metallic taste, and rare hypersensitivity reactions, its rapid and highly specific reversal mechanism has transformed recovery from certain NBAs.
What about special considerations for pediatric and geriatric patients? Do their developing or aging bodies affect how these drugs are used?
This is a crucial area for clinical mastery. In pediatrics, extreme caution is needed at birth because the neuromuscular junction is not yet fully developed, making neonates particularly sensitive.
Babies are more sensitive.
Yes. Acetylcholine, due to its risks, is generally not safe for routine pediatric use and is reserved for extreme emergencies, such as immediate airway securing, when no other options are available. Competitive agents, however, are commonly used in pediatric patients.
Okay.
While their dosage often appears similar to adults, children often exhibit a faster onset and clearance of these drugs, primarily due to higher cardiac output and larger extracellular fluid volumes. An exception is atracurium, which has similar dosage and duration for children over 2 years in adults. Vecuronium, cisatracurium, rocuronium, and mivacurium are also common choices for shorter procedures in children.
And in geriatrics, older adults.
In geriatrics, there are normal age-related changes at the neuromuscular junction itself, like an increased distance between the nerve terminus and the end plate, flatter invaginations, a decreased amount of neurotransmitter per vesicle, and lower vesicle release probability, along with decreased receptor density.
So the connection gets a bit less efficient with age.
You could say that. All of these changes contribute to a reduced efficiency of neuromuscular transmission in older adults. Furthermore, general physiological changes common with aging, such as decreased total body water and muscle mass, increased total body fat, and often decreased renal and hepatic function, also significantly affect NMBA action.
Body composition changes too.
Right. While succinylcholine dosing is not significantly altered for competitive agents in the elderly, initial dose requirements are often unchanged, but the onset of blockade is typically delayed, and the duration of the block is prolonged.
Slower onset lasts longer.
Often, yes. For kidney or liver-dependent compounds like pancuronium, vecuronium, and rocuronium, plasma clearance times can be prolonged by 30% to 50%. However, atracurium, because of its unique Hoffman elimination pathway that doesn't depend on organ flow for elimination, is largely unaltered in its duration of action in geriatric patients.
So atracurium is useful in the elderly, too.
It can be a very good choice. This nuanced understanding of age-related physiological changes is what separates professional-level knowledge from general awareness and leads to safer, more effective patient care.
That brings us to another important category of muscle-affecting drugs, spasmolytics. These agents are designed to relieve painful muscle spasms. How do these spasms occur in the first place?
Muscle spasms, which are involuntary, repetitive, often painful muscle contractions, typically result from hyperexcitability of alpha motor neurons in the spinal cord.
Overactive motor neurons.
Exactly. This is frequently a consequence of lesions or damage from conditions like spinal cord injury, stroke, or multiple sclerosis. The objective of spasmolytics is to reduce these spasms by acting centrally in the brain and higher centers of the spinal cord, aiming to increase functional capacity and alleviate discomfort.
But many of these agents are only recommended for short-term use due to significant adverse effects, right?
Unfortunately, yes, that's often the case. The orally administered agents in this category include baclofen, benzodiazepines, gabapentin, alpha-2 adrenergic agonists like tizanidine, and cyclobenzaprine.
Let's start with baclofen. What's its mechanism of action in calming these overactive signals?
Baclofen is an orally effective GABA receptor agonist. It essentially mimics the action of GABA, an inhibitory neurotransmitter.
Boosting the calm-down signal.
In a way, yes. It suppresses neurotransmission through multiple mechanisms in both the brain and spinal cord, acting at both pre- and postsynaptic sites to hyperpolarize cell membranes. This hyperpolarization reduces calcium influx into the neurons and decreases the release of excitatory neurotransmitters, thereby effectively inhibiting overactive spinal reflexes. It's like turning down the volume on an overstimulated neural circuit.
And benzodiazepines, like diazepam, while effective for muscle rigidity, are limited by their high abuse potential and significant CNS depressant effects. They work by enhancing GABAergic neurotransmission, increasing inhibitory signaling. Gabapentin, though a cyclic analog of GABA, doesn't directly interact with GABA receptors. That's interesting.
Correct. It's a bit counterintuitive based on the name. Instead, gabapentin reportedly interacts with two specific membrane proteins involved in excitation response coupling. First, the alpha-2 delta subunit of CAV, which is a voltage-gated calcium channel.
Calcium channel target.
Okay, by interacting here, it reduces neuronal calcium currents, thereby calming down nerve activity. Second, it interacts with certain voltage-gated potassium channels like KCNQ23 and homomeric KCNQ3 and KCNQ5. This leads to membrane hyperpolarization and reduced excitability of susceptible neurons.
What about alpha-2 adrenergic agonists like tizanidine? How do they provide relief?
Tizanidine is an alpha-2 adrenergic receptor agonist that provides effective relief from spasticity, particularly in conditions like multiple sclerosis and spinal cord injury. While its precise mechanism isn't fully elucidated, it's thought to act similarly to clonidine, another alpha-2 agonist, but with a significant advantage.
Which is?
It has a lesser effect on lowering blood pressure at concentrations that effectively relieve spasm. This makes it a more favorable option for many patients compared to clonidine.
It has a relatively short half-life and requires careful titration, both up and down, to avoid adverse effects. And it has significant drug interactions with CYP1A2 inhibitors.
Yes. Very slow tapering of the dose is essential when discontinuing tizanidine to avoid rebound spasms, tachycardia, and hypertension. Common side effects include dizziness, sedation, and dry mouth. Its metabolism is significantly affected by potent CYP1A2 inhibitors enzymes in the liver that break down drugs like fluvoxamine and ciprofloxacin, which can drastically increase tizanidine's concentration in the body.
So other drugs can make its levels skyrocket?
Potentially, yes. It also has additive effects with other CNS depressants and should be used cautiously with many other drug classes.
And cyclobenzaprine is pharmacologically related to tricyclic antidepressants. It's used for the short-term reduction of painful muscle spasms resulting from acute peripheral injury, but notably not for central neurological conditions.
That's right, more for acute muscle strain type situations. It acts centrally, likely related to its 5-HT2 receptor antagonist activity.
Serotonin involvement. Interesting.
It's typically administered orally, often 5 milligrams 3 times a day or as needed, with 1 dose at bedtime, and its use is generally limited to about 2 weeks. It also interacts with MAO inhibitors and other CNS depressants, requiring careful prescribing.
And then there are peripherally acting antispasmodics, like the notorious botulinum toxin, Botox.
Yes, botulinum toxin. This is a truly remarkable and potent substance. There are multiple non-equivalent preparations available, such as ibotulinum toxin A, incobotulinum toxin A, and onabotulinum toxin A.
Different brands aren't interchangeable.
Definitely not. While their specific units of activity differ, they all share the same fundamental mechanism. They potently block acetylcholine release peripherally. They do this by binding to cholinergic neurons, entering the cell, and then enzymatically cleaving specific proteins called snare proteins.
Snare proteins.
Yes, these are absolutely essential for the fusion of neurotransmitter vesicles with the cell membrane and subsequent release of acetylcholine. By cleaving them, the toxin prevents the release.
So it stops the signal before it's even sent.
Exactly. The result is a profound, flaccid paralysis of skeletal muscle and diminished activity of both parasympathetic and sympathetic cholinergic synapses.
And the duration of this inhibition is quite long, lasting weeks to about 3 or 4 months, because the restoration of function requires nerve sprouting. That's why it's become so popular for cosmetic uses like treating wrinkles, because it's a temporary effect that needs readministration.
Exactly. It was originally approved for specific ocular conditions like strabismus, crossed eyes, and blepharospasm, involuntary eyelid spasms, as well as hemifacial spasms. But its therapeutic uses have expanded to other localized spasms and dystonias, and even for conditions affecting the lower esophageal sphincter or anal fissures.
But it's incredibly toxic.
Extremely poisonous. Botulinum toxin is one of the most potent substances known, with lethal doses in the nanogram per kilogram range, particularly for intramuscular or intravenous administration. The FDA requires a prominent boxed warning on these preparations.
A black box warning. Serious stuff.
Very serious. Alerting practitioners and patients to the critical risk of toxin spread from the injection site, which could potentially lead to life-threatening respiratory paralysis. This is why it's so important that these preparations are not considered interchangeable.
So if someone shows signs of botulism, prompt antitoxin administration and long-term supportive therapy are critical. What about dantrolene?
Dantrolene is another critical peripherally acting antispasmodic. Its unique mechanism of action involves inhibiting calcium release from the sarcoplasmic reticulum of skeletal muscle cells.
Stopping calcium release inside the muscle cell?
Precisely. It does this by limiting the capacity of calcium in a protein called calmodulin to activate the ryanodine receptor, RYR1, which is the key calcium release channel. Dantrolene is indicated for chronic muscle spasticity resulting from upper motor neuron disorders, such as spinal cord injury, stroke, cerebral palsy, and multiple sclerosis.
And critically for malignant hyperthermia.
Yes. Crucially, it is also the primary treatment and preventative measure for malignant hypothermia and is used off-label for neuroleptic malignant syndrome.
But because of its peripheral action, it causes generalized muscle weakness, which is a significant side effect. So it's usually reserved for non-ambulatory patients with severe spasticity. And chronic use comes with a risk of hepatotoxicity, requiring frequent liver function tests.
That's a vital consideration for its long-term use, as clinicians must balance its benefits against this risk by aiming for the lowest effective dose. There are also miscellaneous agents for symptomatic relief, like carisoprodol, which is metabolized to meprobamate and relies heavily on its sedative properties and blockade of pain pathways.
Kind of like a muscle relaxant that makes you sleepy.
That's a component, yes. Another interesting agent is tetrabenazine, used for Huntington's chorea. It works by inhibiting VMAT2, vesicular monoamine transporter 2, which effectively depletes the vesicular stores of dopamine in CNS dopaminergic neurons, reducing the involuntary movements characteristic of chorea.
Now let's zoom out to the broader nervous system, specifically ganglionic neurotransmission, the autonomic relay stations. What's the role of the neural nicotinic receptor, NN, here, given our earlier discussion of it?
Right, the N receptors in the ganglia. Neurotransmission in autonomic ganglia is a fascinating multi-layered process. It begins with acetylcholine release from preganglionic nerve fibers, which then leads to a rapid depolarization of the postsynaptic membranes via N receptor activation.
The initial signal.
Exactly. Unlike the neuromuscular junction, ganglia don't have discrete, highly localized N plates. Instead, the N receptors are distributed more broadly on the dendrites and nerve cell bodies. While the basic ion channel characteristics of ganglionic and NMJ nicotinic receptors are similar, the ganglionic N receptors in particular feature multiple subunits, with alpha-3 and beta-4 being the most abundant and functionally important.
And they're sensitive to those blockers like hexamethonium.
Yes, these ganglionic N receptors are notably sensitive to classical blocking agents like hexamethonium and trimethophan.
So it's not just a simple, immediate on-off switch here, is it? Stimulation of the preganglionic nerve actually elicits at least 4 different distinct changes in postsynaptic membrane potential. This sounds incredibly complex and finely tuned.
This is where the true mastery of ganglionic transmission lies. It's not just one signal. You have a sequence of events.
Okay, break it down for us.
First, the initial EPFP, excitatory postsynaptic potential. This is the rapid primary response, mediated by the nicotinic receptors involving inward sodium and possibly calcium current. If this initial potential is strong enough, it directly triggers an action potential in the postsynaptic neuron.
The go signal.
Right. Second, the IPSP, inhibitory postsynaptic potential. Following the initial EPSP, some ganglia exhibit an IPSP, which is mediated by M2 muscarinic receptors that are GIGO-coupled. This is an inhibitory signal. Interestingly, catecholamines like dopamine and norepinephrine, often released from interneurons within the ganglion, can also contribute to this hyperpolarization.
So an excite then and inhibit.
Sometimes, yes. Third, the slow EPSP. This potential has a longer latency and duration, lasting typically between 10 to 30 seconds. It's mediated by M1 muscarinic receptors, which are GQG11 coupled and are blocked by atropine. This slow EPSP results from a decreased potassium conductance, specifically an inhibition of what's called the M current.
M current. What does inhibiting that do?
Inhibiting the M current, which normally helps stabilize the membrane, effectively makes the neuron more excitable to subsequent fast signals and sort of primes the pump.
Makes it easier to fire again later. Got it.
Fourth, the late slow EPSP. This is the most prolonged response, lasting for several minutes. It's mediated not by acetylcholine directly, but by a myriad of peptides released from presynaptic nerve endings or from interneurons within specific ganglia.
Peptides causing long-lasting effects.
Yes, these peptides are often co-released with acetylcholine, and their relative stability extends their influence far beyond the immediate synaptic transmission.
So these subsequent events, the IPSP, the slow EPSP, and the late slow EPSP, are insensitive to N antagonists and primarily modulate the probability that a subsequent EPSP will reach the threshold for triggering a spike. They essentially fine-tune the overall signal transmission, adding layers of control.
Exactly. They act as modulators, providing context and regulating the overall excitability of the ganglionic neuron. Other neurotransmitters like serotonin, 5-HT, and GABA can also modulate ganglionic transmission, further adding to this intricate regulatory network. It's a beautifully complex system designed to integrate and filter information.
Ganglionic stimulating agents are used mostly as research tools, with limited therapeutic use. They fall into two categories: nicotine-like rapid-onset stimulants and muscarinic receptor agonists that have delayed excitatory effects.
That's a good summary. What's truly fascinating here is how nicotine itself plays such a complex and powerful role in both stimulation and dependence. It's of immense medical significance due to its inherent toxicity, its ubiquitous presence in tobacco products, and its profound propensity for dependence.
The addiction aspect is huge.
Absolutely. Chemically, it's a natural liquid alkaloid, colorless and volatile when pure, but it quickly turns brown and acquires the characteristic tobacco odor upon air exposure.
Its mechanism of action is described as biphasic. It can both stimulate and desensitize receptors. This makes its physiological effects incredibly complex and often unpredictable, which sounds like a challenge for studying it.
It's a significant challenge, as the ultimate physiological response is a summation of both stimulatory and inhibitory effects, highly dependent on dose and context. For example, nicotine can increase heart rate by stimulating sympathetic ganglia, or conversely, paralyze parasympathetic cardiac ganglia.
So it can speed up the heart in different ways.
Yes. It can also slow heart rate by paralyzing sympathetic ganglia or stimulating parasympathetic cardiac ganglia. Furthermore, its effects are influenced by a complex interplay with chemoreceptors, the central nervous system, and baroreceptor reflexes, making its cardiovascular effects particularly nuanced.
And it has a similar biphasic action on the adrenal medulla. Small doses evoke the discharge of catecholamines, like adrenaline, but larger doses actually prevent their release.
That's right. In the peripheral nervous system, nicotine's major action is an initial transient stimulation, followed by a more persistent depression of all autonomic ganglia. At lower concentrations, typically around 200 nanomolar, which are representative of levels seen with tobacco use.
Like from smoking a cigarette.
Exactly. Nicotine's effects reflect its higher affinity for the neuronal nicotinic receptor, specifically the alpha-4 beta-2 subtype, compared to the neuromuscular junction receptor, alpha-1 beta-1 gamma delta. This difference in affinity is critical for understanding its addictive properties.
It prefers the brain receptors.
At those concentrations, yes. It also stimulates various sensory receptors like mechanoreceptors, chemoreceptors in the carotid body, thermal receptors, and pain receptors. It's interesting that hexamethonium can prevent this stimulation by nicotine, but not by physiological stimuli.
That tells you something about the pathway.
It does. It provides a fascinating insight into the specific receptor mediation of nicotine's effects. In the central nervous system, nicotine markedly stimulates the CNS. Low doses can produce weak analgesia or pain relief, while higher doses lead to tremors and eventually convulsions.
CNS stimulant effects.
Yes, excitation of respiration is a prominent effect. Large doses act directly on the medulla oblongata, the brainstem region controlling breathing, while smaller doses augment respiration reflexly via the carotid and aortic body chemoreceptors, which sense blood oxygen levels.
But high doses lead to profound CNS depression, and sadly, death often results from respiratory failure due to a combination of central paralysis of the respiratory drive and peripheral blockade of the diaphragm and intercostal muscles.
A deadly combination.
Yeah.
It also induces vomiting through both central effects on the chemoreceptor trigger zone in the medulla oblongata and peripheral actions activating vagal and spinal afferents.
What's truly intriguing and a major area of research for addiction is its role in pleasure and reward.
Absolutely. The stimulatory and pleasure-reward actions of nicotine appear to result from the projunctional release of excitatory amino acids, dopamine, and other biogenic amines from various CNS centers,
The dopamine reward pathway.
a key player. And with chronic exposure to nicotine, a remarkable phenomenon occurs. There's a marked increase in the density or number of nicotinic receptors, which is thought to significantly contribute to the development of tolerance and dependence.
The body makes more receptors.
It seems so. Nicotine essentially acts as an intracellular pharmacological chaperone, stabilizing newly formed receptor pentamers in the endoplasmic reticulum and increasing the receptor's half-life on the cell surface. This is a profound molecular mechanism explaining how the body adapts to chronic nicotine exposure, making it harder to quit.
So it's not just about binding, it's actively influencing how the body expresses and maintains these receptors, contributing to addiction. What about its absorption, distribution, metabolism, and excretion? How does the body handle it?
Nicotine is readily absorbed from the respiratory tract, which is why smoking is so effective, as well as from buccal membranes like chewing tobacco, and even through the skin, leading to severe poisoning from percutaneous absorption.
You can get poisoned through the skin.
Yes, especially with concentrated forms like insecticides. While stomach absorption is limited due to its strong toxicity, intestinal absorption is quite efficient. Nicotine from chewing tobacco is absorbed more slowly, but results in a longer duration of effect compared to smoking. An average cigarette contains 6 to 11 milligrams of nicotine, delivering typically 1 to 3 milligrams systemically to the smoker.
Only 1 to 3 milligram gets in.
Typically. But this bioavailability can increase up to threefold, with factors like puffing intensity and technique.
And the body processes it efficiently. 80% to 90% is altered, mainly in the liver, with cotinine as the major metabolite. Its half-life after inhalation is about 2 hours, and it's rapidly eliminated by the kidney, with excretion diminishing in alkaline urine. It can even be excreted in the milk of lactating women.
Acute adverse effects and poisoning from nicotine are severe and potentially fatal. Accidental ingestion, particularly in children from tobacco products or insecticide sprays, is a serious concern. The acutely fatal dose for an adult is estimated to be around 60 milligrams.
60 milligrams, that's not a huge amount.
No, it's quite toxic. Symptoms typically have a rapid onset. Nausea, profuse salivation, abdominal pain, vomiting, and diarrhea, often accompanied by cold sweats, headache, dizziness, disturbed hearing and vision, and mental confusion, leading to marked weakness and prostration. Blood pressure falls, breathing becomes difficult, and the pulse becomes weak, rapid, and irregular. This can rapidly progress to collapse and terminal convulsions. Death can occur within minutes from respiratory failure.
Frighteningly fast. For treatment of acute poisoning, inducing vomiting or gastric lavage is crucial, being careful to avoid alkaline solutions, followed by activated charcoal slurry to absorb any remaining toxin. Respiratory assistance and aggressive treatment for shock are also necessary.
Now, let's turn to ganglionic blocking agents. These compounds actually represented the first effective pharmacological therapy for hypertension, a major public health issue.
The first blood pressure drugs?
Among the first effective ones, yes. However, because ganglionic transmission plays such a fundamental and widespread role in both the sympathetic and parasympathetic branches of the autonomic nervous system, their antihypertensive action comes with a multitude of often undesirable and severe side effects.
They block too much.
In essence, yes. Like mecamylamine, a secondary amine that despite being orally bioavailable for moderate to severe hypertension, still carries significant side effects due to its mechanism. The physiological effects of most of these agents can largely be predicted by understanding the dominant autonomic tone at various organs.
Okay, how does that work?
For instance, in the context of arterioles, sympathetic ganglia are dominant, releasing norepinephrine to constrict blood vessels. Therefore, blockade of sympathetic ganglia interrupts this adrenergic control, causing widespread vasodilation, improved peripheral blood flow in some beds, and a significant fall in blood pressure.
Which is what you want for hypertension.
Right. But this generalized ganglionic blockade also leads to a host of other effects, including atony of the bladder and GI tract, meaning they lose their normal muscle, tone cycloplegia, paralysis of the ciliary muscle in the eye, impairing accommodation, xerostomia, severe dry mouth, diminished perspiration, and critically a profound abolition of circulatory reflexes, leading to severe postural hypotension.
Feeling faint when you stand up.
Severely so. These widespread, often debilitating side effects severely limit their therapeutic efficacy and patient tolerability.
Cardiovascular effects also heavily depend on the existing sympathetic tone. Blood pressure may drop minimally in someone lying down with normal blood pressure, but there's a marked fall when sitting or standing, which critically limits their use in ambulatory patients due to the risk of fainting. And heart rate changes depend on the existing vagal tone, often leading to a mild tachycardia or increased heart rate, which usually accompanies complete blockade.
Cardiac output can be reduced in patients with normal cardiac function, primarily due to venodilation and peripheral pooling of blood, which decreases the venous return to the heart. However, paradoxically, in patients with cardiac failure, cardiac output can actually increase because the reduced peripheral resistance lessens the heart's workload.
Interesting. And their ADME varies too.
Yes. Quaternary and sulfonium compounds are poorly and unpredictably absorbed from the GI tract due to their ionized nature and poor membrane penetration, and they are confined to the extracellular space, largely excreted unchanged by the kidney. Mecamylamine, being a secondary aramine, has less erratic absorption but concentrates in the liver and kidney and is slowly excreted largely unchanged. Its use carries a risk of reduced bowel activity and even paralytic ileus. Trimethophan, for instance, was once used for controlled hypotension during surgery and for hypertensive emergencies, but it is no longer marketed in the U.S. due to its unfavorable side effect profile.
So these older drugs had too many problems, which brings us to a huge contemporary public health challenge. Nicotine addiction and the strategies for smoking cessation. Nicotine as a therapeutic agent is primarily used to aid in quitting smoking.
Indeed. The primary goals of pharmacotherapy for smoking cessation are twofold. First, to effectively reduce the intense nicotine craving that makes quitting so difficult, and second, to inhibit the reinforcing or rewarding effects that smokers experience from nicotine, thus breaking the positive association with smoking.
Tackle the craving and the reward.
Exactly. Current approaches include nicotine replacement therapy, NRT, by propion, a CNS active agent that acts as a weak nicotinic antagonist, among other mechanisms, and innovative partial agonists of the nicotinic A-tertiary receptor, most notably varenicline.
Varenicline like Chantix.
Yes. Electronic cigarettes, or vaping, are also part of this complex conversation, often debated as a safer alternative, though their claims are questionable given their growing popularity and use of flavored tobaccos, particularly among teenagers. It's a nuanced public health issue.
The current consensus among professionals is that NRT, bupropion, and varenicline all demonstrably help smokers quit. The safety and efficacy of NRT are clearly established, and interestingly, the highest rates of smoking cessation, around 30% success at 6 months of abstinence, result from the combination of NRT, such as a patch plus an inhaler, and varenicline.
But what's absolutely crucial for successful long-term cessation, and consistently shown in meta-analyses, is that behavioral support, whether it's counseling, telephone support, or other forms of intervention, when used in addition to pharmacological treatment, significantly increases the likelihood of smoking cessation by about 10% to 25%.
So the drugs help, but you really need the support too.
It powerfully underscores the multifaceted nature of addiction and the necessity of a comprehensive approach that addresses both the biological and psychological components.
NRT itself comes in various forms, making it accessible to many. Over-the-counter options include gums, lozenges, and transdermal patches. Prescription options include nasal sprays and vapor inhalers. These different delivery systems produce different exposure patterns for nicotine, allowing for personalized approaches.
And their efficacy is further enhanced when integrated with counseling and motivational therapy, reinforcing that comprehensive approach. Cetacine, a plant alkaloid, is another fascinating agent in this space, though it's not yet approved in Europe or the US.
So fascinating. Never heard of it.
It acts as a partial agonist at nicotinic ACE receptors, with a particular affinity for the alpha-4 beta-2 subtype. It's taken orally, has a half-life of about 5 hours, and generally causes mild gastrointestinal side effects. Small clinical trials have shown its effectiveness to be similar to both NRT and varenicline, indicating its strong potential.
And then there's varenicline, which is actually a cytosine-based therapeutic. It's typically started at a low dose and then gradually titrated up over several days. Its mechanism of action is incredibly clever. It's a selective partial agonist at the alpha-beta-2 receptors, which are considered the principal subtype involved in mediating nicotine addiction's rewarding effects.
By binding to these receptors as a partial agonist, varenicline essentially blocks the ability of full agonists, like nicotine from a cigarette, to generate the full reward experience that drives addiction.
It blocks the high, so to speak.
It diminishes it significantly, but because it's a partial agonist, it also provides a low level of receptor activation on its own. This means it doesn't promote the severe withdrawal effects like intense cravings or mood disturbances that a full antagonist might.
So it eases withdrawal while blocking the reward. Best of both worlds.
That's the idea. Varenicline also acts as a lower affinity full agonist at the alpha-7 subtype and shows weak activity toward other receptors. Clinical studies have consistently shown it to be more effective than placebo, the nicotine patch, or bupropion for achieving sustained abstinence.
It has high oral bioavailability and is primarily excreted unchanged in the urine, so dosage reduction is recommended for patients with renal impairment. And while it previously had an FDA black box warning for serious psychiatric effects, like suicidal ideation,
That was a major concern.
recent large-scale studies have shown no significant increase in such events directly attributable to varenicline compared to the nicotine patch or placebo.
Right, the data evolved. However, clinicians are still advised to monitor patients for any behavioral or psychiatric changes during treatment, as these, if they occur, typically resolve upon discontinuation of the medication. This evolving understanding of drug safety is key in pharmacology.
So what does this all mean for us, having taken this deep dive? We've journeyed from the fundamental, almost microscopic structure of the nicotinic acetylcholine receptor, discovering how its precise design underpins everything from the simplest muscle movement to the complex, involuntary control of our autonomic nervous system.
We explored the dramatic history of curare, an ancient arrow poison, and how its discovery paved the way for modern neuromuscular blockers, which are now essential, life-saving tools in surgery and critical care.
We then uncovered the diverse world of spasmolytics, from centrally acting agents like baclofen that calm overactive spinal circuits, to the incredibly potent peripherally acting botulinum toxins, each with a unique and powerful way of calming overactive muscles.
And finally, we saw the profound dual impact of nicotine, a substance that both stimulates and blocks, revealing its complex role in addiction, and the innovative multifaceted strategies we now have to help people quit smoking, combining pharmacological breakthroughs with essential behavioral support.
What stands out to you as the most surprising connection from today's deep dive? Perhaps it's how a single, seemingly simple receptor, the nicotinic ACE receptor, is involved in such an astonishing breadth of critical bodily functions,
Aurelia is everywhere.
and how understanding its subtle subtypes and precise mechanisms allows us to develop such targeted and precise medical interventions. Or maybe it's the sheer power and specificity of natural toxins, and how, in the hands of scientists, they have shaped our fundamental understanding of human physiology and paved the way for entirely new classes of drugs.
From poisons to probes to prescription.
Exactly. This deep dive shows us profoundly how mastering fundamental biology can directly lead to real-world applications that impact health on a massive scale, from facilitating life-saving surgeries to addressing widespread public health challenges like addiction.
Indeed. Consider this as you reflect on what we've explored. The intricate balance of chemical signals we've discussed today is constantly at play within your own body, a symphony of molecular interactions. How might future advances in understanding these even more subtle molecular dance steps lead to even more precise and personalized treatments for a wider range of neurological conditions?
The future possibilities.
Perhaps going beyond just blocking or stimulating and instead finding ways to truly rewire these pathways for long-term health and function. The deeper we go, the more we realize how much more there is to discover and how intimately connected our understanding of the smallest molecules is to the grand tapestry of human health.